We're staying in the phenylpiperidine family today, looking at the drug that sits right at the top of the potency scale in routine clinical use. Sufentanil showed up in 1974, just over a decade after fentanyl, built by swapping in a thiophene ring, where fentanyl has a phenyl group. That small structural tweak produces a drug that's 5 to 10 times stronger than fentanyl, and somewhere between 500 and 1,000 times stronger than morphine. Let's break down what that structural change actually buys you clinically, where the extra potency comes from. The jump in strength tracks directly with how tightly sufentanil grips opioid receptors. It simply binds harder than fentanyl does. You can see this reflected in EEG studies. The plasma concentration needed to produce half of the maximum slowing on the EEG is 12 times lower for sufentanil than fentanyl. There's also a genuinely reassuring safety margin built into this drug. The gap between an effective analgesic dose and the dose that triggers seizures in animal models is 1,000-fold for sufentanil, compared to only 160-fold for fentanyl. That wider margin matters when you're pushing large opioid doses as the primary anesthetic, which is exactly where sufentanil has traditionally shined. How it works. Same receptor story as every phenylpiperidine opioid. Mu receptors dominate, kappa and delta play minor supporting roles. Sufentanil is described as a selective mu agonist. Its affinity skews even more heavily toward mu than fentanyl's does. Activating those receptors gets you the analgesia, the sedation, and the blunted sympathetic response you're looking for, alongside the respiratory depression you have to actively manage. How fast it works, and why. The onset lands around 1 to 3 minutes. Peak effect somewhere between 5 and 10 minutes, with a single dose lasting roughly 20 to 45 minutes. Just like fentanyl, plasma concentration and brain-level effect aren't the same moment in time. There's a lag while the drug actually equilibrates into the CNS. For sufentanil, that equilibration time runs around 6.2 minutes, essentially identical to fentanyl's 6.8 minutes. This high tissue affinity comes straight from how lipophilic sufentanil is. That fat solubility is what lets it cross into the brain so readily in the first place. Small doses terminate the same way fentanyls do, rapid redistribution out of the brain and into inactive tissue. But push large or repeated doses and you can start seeing cumulative effect. The peripheral tissue starts filling up, and the drug sticks around longer than a single small dose would. Sufentanil also gets soaked up by the lungs on first pass, roughly 60% of an initial IV dose, similar to what fentanyl does, and notably more than morphine's roughly 7% or alfentanil's roughly 10%. Destitution, where it differs from fentanyl. Here's a genuinely interesting contrast. Sufentanil is bound to plasma protein at about 92.5%, noticeably higher than fentanyl's 79 to 87%. That heavier protein binding is exactly why sufentanil ends up with a smaller volume of distribution than fentanyl, around 2 to 3 liters per kilogram, despite both drugs being highly lipophilic. Most of that binding happens to a specific protein, alpha-1 acid glycoprotein. And this protein's levels aren't fixed. They vary up to 3-fold, even among healthy people, and they rise further after surgery, which can shift how much free, active sufentanil is actually circulating at any given moment. This has real implications in neonates and infants, who naturally have lower levels of this binding protein than older children and adults. Less protein to bind to means a higher free fraction of active drug, which likely explains why fentanyl and its relatives produce anesthesia and respiratory depression at lower doses in newborns than they do in adults. Obesity pushes things the other direction. Both volume of distribution and elimination half-time increase in obese patients, almost certainly reflecting how much this drug loves fat tissue. What the liver does to it. Sufentanil gets broken down rapidly through 2 pathways: N-dealkylation at the piperidine nitrogen and O-demethylation. The N-dealkylation products are pharmacologically dead, completely inactive. But O-demethylation produces D-methylsufentanil, which retains roughly 10% of the parent drug's activity. Weak, but not nothing. Less than 1% of an administered dose shows up unchanged in urine. Interestingly, sufentanil's high lipid solubility promotes extensive reabsorption of free drug in the renal tubules, while also giving it easy access to the liver's metabolic machinery. Because hepatic extraction is so extensive, clearance tracks closely with hepatic blood flow, but doesn't really shift much based on changes in the liver's actual metabolic capacity. Metabolites clear out roughly evenly between urine and stool, with about 30% appearing as conjugated compounds, which hints that normal kidney function plays a real role in fully clearing this drug. Worth flagging, prolonged respiratory depression tied to abnormally elevated sufentanil levels has been documented in a patient with chronic renal failure. The half-life story. Elimination half-time falls somewhere between fentanyls and alfentanyls, right in the middle of that family. A single IV dose behaves similarly, whether or not the patient has cirrhosis. Liver disease alone doesn't dramatically change a single dose elimination half-time. Elderly patients undergoing abdominal aortic surgery have shown prolonged elimination, worth keeping in mind for that population. Dosing. Straight analgesia, 0.1 to 0.4 micrograms per kilogram IV, blunting the sympathetic surge from laryngoscopy or surgical stimulation, 0.2 to 0.5 micrograms per kilogram IV, epidurally, 10 to 20 micrograms, intrathecally, 2.5 to 10 micrograms. How it compares clinically to fentanyl. In volunteer studies, a single sufentanil dose of 0.1 to 0.4 micrograms per kilogram IV produced longer analgesia and less ventilatory depression than a comparable fentanyl dose of 1 to 4 micrograms per kilogram IV. Like other opioids, sufentanil drops cerebral metabolic oxygen demand, and cerebral blood flow tends to decrease or stay unchanged. Bradycardia from sufentanil may actually be significant enough to reduce cardiac output, worth watching for, particularly in patients who depend on heart rate to maintain their output. And just like fentanyl, delayed respiratory depression has been described after sufentanil administration, the same secondary peak phenomenon we talked about in the fentanyl lecture. Chest wall rigidity. Using large opioid doses to induce anesthesia, whether sufentanil or fentanyl, can rigidify the chest wall and abdominal muscles. That rigidity makes positive pressure ventilation genuinely difficult. And here's a subtle point worth knowing. The actual obstruction during this rigidity may be happening at the level of the glottis or above, rather than purely from muscle stiffness itself, which is why intubating the trachea can overcome the obstruction even before the rigidity is pharmacologically reversed. Respiratory effects. The full picture. Sufentanil depresses respiratory rate, tidal volume, and blunts the response to both rising CO2 and falling oxygen, the standard opioid pattern. Watch for delayed respiratory depression, especially after large or repeated doses. And large doses can bring chest wall rigidity, abdominal rigidity, and glottic closure into the picture alongside the expected respiratory depression. Cardiovascular effects. Minimal myocardial depression, stable blood pressure, reduced sympathetic tone. Bradycardia shows up regularly. And critically, no significant histamine release, the same defining trait fentanyl carries, which is exactly why sufentanil earned its place as a preferred agent in cardiac anesthesia. Clinical uses. Major intraoperative analgesia, thoracic and vascular surgery in particular. Cardiac anesthesia, where hemodynamic stability and the absence of histamine release make it especially valuable. Neuroanesthesia, lowering cerebral metabolic oxygen demand and cerebral blood flow. Epidural and intrathecal analgesia, including postoperative and labor pain control. ICU sedation, usually run as a continuous infusion. The common side effect list. Respiratory depression, bradycardia, sedation, nausea, vomiting, pruritus, constipation, the usual opioid roster. And the ones that stand out as more distinctive: chest wall rigidity, delayed respiratory depression, and skeletal muscle rigidity more broadly. Contraindications and cautions. Use extra care in severe respiratory disease, obstructive sleep apnea, advanced age, concurrent CNS, depressants, hepatic dysfunction, renal failure, and bradyarrhythmias. And be cautious combining sufentanil with benzodiazepines, propofol, or other sedatives. The same synergy that makes fentanyl so useful in combination applies here too, and carries the same respiratory depression risk. How it stacks up against the other synthetic opioids. Sufentanil sits at the top, 500 to 1,000 times morphine's potency, onset 1 to 3 minutes, duration 20 to 45 minutes, no significant histamine release. Fentanyl trails behind at 75 to 125 times morphine's potency, similar onset, duration 30 to 60 minutes. Alfentanil comes in much weaker, 10 to 20 times morphine's potency, but with the fastest practical onset for titrating against brief stimuli, and the shortest single-dose duration of the group, 10 to 15 minutes. Remifentanil sits at 100 to 200 times morphine's potency, onset around 1 minute, and an ultra-short duration of just 5 to 10 minutes, thanks to its unique ester metabolism. Morphine, far weaker and slower than any of these, remains the one with meaningfully more histamine release. The high-yield summary. Sufentanil, a thionyl analog of fentanyl, 5 to 10 times more potent than fentanyl, 500 to 1,000 times more potent than morphine. Extremely lipophilic, with an effect site equilibration time of about 6.2 minutes, nearly identical to fentanyl. Roughly 60% of an initial dose undergoes first-pass pulmonary uptake. 92.5% protein bound, higher than fentanyl, which gives it a smaller volume of distribution. No significant histamine release, making it a preferred choice for cardiac anesthesia. Context-sensitive half-time can actually be shorter than alfentanil's during prolonged infusions, a genuine pharmacokinetic advantage. And rapid administration of large doses carries the same chest wall rigidity risk we saw with fentanyl. Pulling it together. Sufentanil. Take fentanyl's profile, tighten the receptor binding, and you get a drug that's dramatically more potent, with a wider margin between effective dose and dangerous dose. And over long infusions, sometimes a cleaner recovery profile too. Same family, same core risks. Respiratory depression, bradycardia, chest wall rigidity with rapid large doses. Just turned up several hundredfold in strength. I'm Anesthesia Buddy. Stay sharp. See you in the next one.